Hey guys, so today we are gonna learn about the Barrett's esophagus. So Barrett's esophagus means it is a pre-malignant condition. Okay, so it is a pre-malignant condition in which the normal squamous lining of the lower esophagus. Now you have the esophagus. Okay, so the normally the esophagus is lined by the squamous. Okay, squamous epithelium. So the normal squamous epithelium lining of the lower esophagus, it is replaced by the columnar mucosa or the columnar epithelium. Okay, now the columnar epithelium that is replaced means the columnar epithelium that is replacing the squamous epithelium. So some of the columnar epithelium may contain the areas of the metaplasia. This will turn into the malignancy. So that is why it is known as pre-malignant condition. Okay, now coming to etiology. In the etiology, age it is occurring more than 50 years and sex is males are more common than the females. And the risk factor one is chronic GERD. Okay, gastrointestinal esophageal reflux disease. Okay, gastroesophageal reflux disease. So this is the risk factors. Okay, so why it is a risk factor? Now I will tell you. Because in the chronic GERD, what will occur? Reflux of the contents will occur. So because of that, the esophageal epithelium is always exposed to this acid. And just now what I told you, the normal squamous epithelium. So lining, the normal epithelium is squamous epithelium. So this squamous epithelium, it is not resistant to the acid. Okay, it is not resistant. Okay, so it is not resistant. So because it is not resistant, this is changing to the columnar, which is resistant to the acid. So that is why it is changing. There is change in the epithelium because of the acid. So I'll read you. It is an adaptive response to the chronic gastroesophageal reflux. Metaplastic columnar epithelium develops because it is more resistant to the acid pepsin damage than squamous epithelium, as now I told you. Okay, now endoscopically, Barrett's epithelium can be seen as a continuous sheet. Okay, in the now your endoscopy, you pass the endoscopy into the esophagus. So now endoscopically in the Barrett's epithelium, you are gonna see it as a continuous sheet and red velvety appearance, and you can see finger like projections into the esophagus. Okay, remember this: continuous sheath, red velvety appearance, and the finger like projections into the esophagus. Okay, now if we come to the classification, now coming to the classification, it is classified into long segment and the short segment. So long segment, when you will call long segment, is when the metaplasia is more than 3 centimeters, it is called as long segment Barrett's esophagus, and short segment is metaplasia obviously less than 3 centimeters. Okay, so this is this. And investigations, obviously I told you endoscopy and biopsy. And in the endoscopy, you are gonna use the indigo caramine spray to detect the intestinal metaplasia and any dysplastic changes. Okay, now in the biopsy, you are gonna use the Alcian blue stain. Okay, this Alcian blue stain, it will detect the mucin containing globulate cells. Okay, so these globulate cells are the hallmarks of the Barrett's esophagus. Okay, remember, endoscopy, indigo caramine spray, and in the biopsy you are going to use Alcian blue stain. It will detect the mucin containing globulate cells, and this is the hallmark of the Barrett's esophagus. Now coming to the treatment. In the treatment, you are going to do esophagectomy involved region. Now if this is the involved region, this thing you are gonna cut, remove and throw out. Okay, and the radio frequency ablation. Radio frequency means the same esophagectomy you are gonna cut. Radio frequency means using the radio waves you are gonna damage the metaplastic changes. In the same way, photodynamic therapy. Okay, in the photodynamic you are gonna use the light rays to damage the changed metaplastic cells. Okay, so the treatment involve esophagectomy and the radio frequency photodynamic therapy. Okay, I hope you guys understood this topic. Thank you for watching. Please subscribe.